experts panel. And so for those of you that have additional questions, please write them down and bring them to that session. So our next speaker comes to us from Rainbow Babies and Children's Hospital in Cleveland, Ohio. Terri Schindler is a registered dietitian who will discuss various methods of addressing nutritional needs in people with CF. Please help me welcome Mrs. Schindler, Miss Schindler. Here you are. Wherever it works there.
Okay, great.
Okay, thank you.
Thank you. First of all, thank you for the invitation to come and speak today. It's been a wonderful conference so far. I've learned so much. This is the first time I've been at a CFRI conference, so it's been a pleasure so far. And I, like the other speakers, was contacted by Isabel with a very long laundry list of things to discuss in just 45 minutes and leaving 10 to 15 minutes for questions and answers. And thank you, Michael Boyle, for cutting that time even a little bit shorter. I can't be mad at him because he trained one of our attendings at Cleveland, and he's absolutely wonderful, so I can't stay mad at you. So just a little disclosure and background on myself. I am on the advisory board for Abbott Pharmaceuticals. Isabel asked me to talk a little bit briefly about my experience being a mother of a daughter with cystic fibrosis, as well as working in the healthcare field. I have a bachelor's and a master's degree in nutrition. I've worked in the field of CF nutrition for over 20 years now, starting out at Texas Children's Hospital in Houston, working with inpatients with cystic fibrosis, and wow, what a different population it is now on the good side. And I moved to Cincinnati, Ohio, and worked at the CF Center in Cincinnati for 14 years, working with both inpatients and outpatients with cystic fibrosis. And for the past 6.5 years, I've been working at Rainbow Babies Children's Hospital in Cleveland, Ohio, with adults and pediatrics, mostly outpatient work. We have about 350 patients in Cleveland. A little more than half of those are adults now, which is pretty exciting. And our oldest patient, I believe he's about 63 now. So just talking a little bit about the role of the clinical dietitian, and I wanted to distinguish what the difference was between a dietitian and a nutritionist. A nutritionist really is a generic term, and anybody can really call themselves a nutritionist. It really doesn't necessarily mean that you have any kind of specialized training. However, to be a registered dietitian, you need a minimum of a bachelor's degree, and that coursework needs to be approved by the Academy of Nutrition and Dietetics. You also have to complete an accredited internship, and it's usually about 1 to 2 years, and that's in order to gain supervised practical experience. And then you also have to complete a registry examination, a national registry examination, before becoming officially registered. After you're registered, in order to maintain your registration, you have to complete 75 hours of continuing education every 5 years. So within a 5-year period of time, we have to complete 75 hours of continuing ed. In terms of the CF dietitians, we're so fortunate in this field because we have so many dietitians that are dedicated to cystic fibrosis. Just within North America, we have 39 dietitians that participate as nutrition mentors to other dietitians that are new to the field of CF nutrition. And they gain that classification by gaining experience working in CF, so they have at least 5 years of experience, and also by participating in the CF nutrition community. So it's quite an active community. We have not only the nutrition mentoring program, we have a very active CF nutrition listserv where we have over 400 CF nutrition professionals across the world that contribute thoughts and ideas on clinical issues, as well as share research, as well as education material. And then, I just like to say that I think that dietitians are motivated to help patients. They have to use evidence-based medicine to to guide patients, along with in their nutrition journey, but they also take into account cultural differences and individual patients' needs when making recommendations. And this little depiction here, this comic depiction, I thought was kind of accurate for the view of dietitians in the community, and really true of what we actually do. We're kind of nerds, really. I mean, we're often behind little calculators making our different calculations, calculating BMIs and calorie needs and lipase units per kilogram. So that's actually what we spend a lot of our day doing, behind a calculator. Just briefly, what I'm going to talk about today are a number of topics, so it's going to be brief. And Isabel asked me to provide some take-home points on each of these things. So each one of these topics really could be a 45-minute discussion in their own. So just to let you know that it is going to be a brief discussion on each of them. The first topic is antioxidants. So what are antioxidants? They're substances that are capable of counteracting the damaging effects of oxidation in the tissues. And these damaging effects are caused by free radicals. You get free radicals in your body from just metabolism and also from environmental pollutions. These free radicals damage the tissues inside of your body. And antioxidants can neutralize these free radicals, so they're beneficial in the body. You get antioxidants from vitamins and minerals and enzymes. And those are just a couple examples of free radical damage in cells that may give you like a visual of what free radical damage is. Like the apples, after you cut them open, they turn brown. And that's an example of free radical damage. What do we know about antioxidant research? The Cochrane reviews are a database of systematic reviews and meta-analyses, and they summarize and interpret the results of medical research. The Cochrane Library aims to make the results of well-conducted controlled trials readily available, and it's really a key resource for people in the community in using evidence-based medicine. So it's a wonderful resource to all the care providers. The Cochrane group did look at antioxidant micronutrients in cystic fibrosis, particularly their impact on lung disease. They looked specifically at vitamin E, vitamin C, beta-carotene, and selenium, those particular antioxidants. And they concluded that there's really conflicting evidence regarding these supplements. So they really couldn't say that they provided a clinical benefit, nor could they say that they were totally harmless. So it's a little too soon to say that antioxidants in the form of additional supplementation is beneficial in terms of lung disease in people with CF. So looking specifically at some of the studies, there was a study that looked at CF vitamins. We know some of the CF vitamins, such as Aquadex and Source CF vitamins, have some higher levels of antioxidants, such as vitamin E and beta-carotene. And this small study mentioned here actually showed a reduced incidence of pulmonary exacerbations in people that received the CF vitamins. And this was also true for people that have pancreatic sufficiency. And I mention that because we're never quite sure what to do when somebody has pancreatic sufficiency in terms of recommending vitamins. They absorb pretty well, so they may not need to take any vitamins. But this study shows that perhaps there is a benefit to taking those vitamins in terms of the antioxidant effect, more than just maintaining normal fat-soluble vitamin levels. And also that second study was a review study done after the Cochrane review, and it kind of found the same thing. It looks promising in labs to use these antioxidants, but it's really not been proven in any clinical trials as of yet. However, food is a safe source of antioxidants, so in addition to consuming a high-calorie, high-fat diet, it's certainly recommended to get in adequate antioxidants through fruits and vegetables and nuts and oils. Those are always a safe source of antioxidants and probably very healthy for the body as well. And my next topic is vitamin D. There are 3 sources of vitamin D. Ergocalciferol, which is vitamin D2, is that vitamin form that's usually available by prescription, and it's in that 50,000 international unit dose. And the bone health guidelines that were published by the CF Foundation maybe about 10 years ago or so actually recommended using ergocalciferol once or twice a week to help bring up vitamin D levels in people with CF. And what they soon found out after those guidelines were published, that this is truly ineffective in improving the vitamin D levels. So, most people are using the other form of vitamin D now, which is cholecalciferol vitamin D3. This is the form of vitamin D that you see in the CF vitamins, and it's also what you see in the over-the-counter supplements, such as Nature Made. It's that D3 form. And it's, through a number of studies, been shown to be more effective in bringing up the vitamin D levels in people with CF as well as the general population. And the third source is sunlight. Your body is actually able to synthesize vitamin D through the skin. And it usually takes about 10 to 15 minutes of sun exposure to the arms and legs, particularly in the summertime. That's without sunscreen, because sunscreen does block the absorption of vitamin D. But certainly you wouldn't want to go prolonged periods of time in the sun and risk your chances with skin cancer. So it's a good idea to put that sunscreen on after about 10 to 15 minutes outside. So vitamin D research in CF, it's most well known for its role in bone health. It's important for the absorption of both calcium and phosphorus, which are important components of bone. In the study published in JAMA, it showed an inverse relationship between vitamin D levels and risk of fractures. So basically, the lower the vitamin D level, the higher your risk of fracture, and vice versa. There's also been more studies recently looking at the role of vitamin D in the immune system, and this has been looked at in the general population, and you can apply it to the CF population as well. So the studies mentioned here looked at the reduction in risk of catching influenza during the wintertime when people were given vitamin D supplements. And then there was another study published looking at lower incidence of developing upper respiratory tract infections, which is the common cold, in people who had, these were children who had vitamin D levels above 30, which is the recommended goal. And then also it can reduce your risk of falls. And the first study here showed a significant reduction in falls in postmenopausal women with supplementation. And that may be due to its role in improving neuromuscular function. So that might be why we see less falls in people who have normal vitamin D levels and are taking vitamin D supplements. And why is this important in CF? We know that you're higher risk for fractures when you have cystic fibrosis, and that seems to be independent of what the results are of your bone density or your DEXA scan. So for whatever reason, we see more fractures in the CF population. Can't always determine that risk based on the DEXA scans. And then this study was just published within the last month, and this is kind of an exciting area. Can vitamin D act as an anti-inflammatory in people with CF? This is a relatively small study, double-blinded, placebo-controlled, and they used pretty large doses of vitamin D in this study. So it's not something that I don't think anybody would recommend using in the general population quite yet. I think they use like 250,000 units of vitamin D3 in this study, and it was given to adults when they were in the hospital for pulmonary exacerbation, and it showed a significant reduction in the inflammatory marker, the tumor necrosis factor. And the authors concluded that further studies were needed to confirm this in larger populations and also see the impact on clinical outcomes, and they are moving forward, as far as I know, with a multi-clinic study looking at high-dose vitamin D, these huge, really big boluses in patients. And then I just wanted to briefly touch on the new guidelines for vitamin D. These were just published within the last year by the CF Foundation, and just go over a few main points of the guidelines. The document's a lot longer, and it's available on the CF Foundation website. But one of the first recommendations I want to talk about was checking your vitamin D levels. It's recommended to try to check those near the end of winter, and that's because you will see a variation in your vitamin D level depending on the season. So expectedly, you would see higher vitamin D levels in the summertime and lower vitamin D levels in the wintertime, and that's because of our body's ability to absorb vitamin D from sunlight, and particularly in a place like Cleveland, Ohio, where you really don't get much sun in the middle of December. you would definitely expect to see these variations. So by checking a vitamin D level, say, at the end of February or beginning of March, you'd get what we call a trough. So the lowest level your vitamin D is going to be year-round. So if you know it's above 30 at that time, that it's probably staying above 30 throughout the year. The second recommendation, not surprisingly, was to use cholecalciferol vitamin D3 as opposed to vitamin D2, so they countered the recommendations in the bone health documents. And then finally, they gave guidelines for dosing vitamin D3 to achieve and maintain vitamin D levels above 30 nanograms per milliliter. There's ongoing research on vitamin D, so this may be the lower end of the normal range. So in terms of the effects on the immune system and the effects on inflammation, it may be advisable in the future to up that range to maybe 40 or 50. I think the jury's out quite yet, but down the road that might be the recommendation. So next topic is probiotics. Probiotics are live microorganisms, which, when they're administered in adequate amounts, confer a health benefit on the host. So the bacteria in the gut is healthy. You often don't think of bacteria being healthy, but there actually are some good purposes to having bacteria in the intestinal tract. One of a good example is that the bacteria in the gastrointestinal tract can produce vitamin K, one of the fat-soluble vitamins. People with CF tend to be on frequent courses of antibiotics. This can disrupt your gut flora, and it can cause something called antibiotic-associated diarrhea. And it can also cause an overgrowth of bad bacteria, the antibiotics can, and this gut flora disruption. And Clostridium difficile, which we also know as C. diff, is one of the most notorious of all, causing pretty significant damage to the gut, and it can be life-threatening, particularly in people who are immune-compromised. So the antibiotics that treat anaerobes, anaerobe type of bacteria, such as cephalosporins and clindamycin, those are most notorious for causing antibiotic-associated diarrhea, but really could be any type of antibiotic, particularly the ones that you take orally or through IV, not necessarily inhaled, because not a lot of that is absorbed. So what do we know in terms of probiotic research? The Cochrane group did look at this. This is not specific to the CF population, but they looked at the role in preventing pediatric antibiotic-associated diarrhea. And they found that the data, at least up until 2007, was pretty promising, but still yet inconclusive. They did note that these two particular probiotics seemed to show the most promise when they were co-administered with antibiotics. So lactobacillus, a brand name example of that is Culturelle, and Saccharomyces boulardii, a brand name example of that is Florastor. The Florastor is actually a yeast-based supplement as opposed to a bacterial-based supplement that you see in the Culturelle. They also concluded that they needed better definitions to compare these studies. So some researchers were defining antibiotic-associated diarrhea as having 1 watery stool a day, and some people were defining it as having 3 watery stools a day. It's very difficult to compare studies when people have different definitions that are used. And they also recommended better monitoring for adverse events. So looking specifically in terms of research that's been done in the CF population, this is a pilot study, and basically what that means is a very small trial, and really before somebody dedicates a lot of resources toward looking at a topic in more depth, they want to see in small numbers of patients, did you see any clinical benefit? So this is not definitive by any means, but there was a study published in 2010 in Pediatric Pulmonology looking at the effects of Lactobacillus GG on pulmonary exacerbations. And in that very small group of 10 CF patients, they did find a significant reduction in the rate of pulmonary exacerbations. They didn't see any difference in the PFTs or inflammatory markers. So it's probably will go further with more clinical trials looking at that effect. So if you want to take probiotics, some of the things to consider are to get your doctor's okay. If you're immune compromised, particularly if you have a central line, it's a good idea to make sure you get your physician's approval before using these products. choose the product at the right quantity to treat what you're intending to treat, such as antibiotic-associated diarrhea. Some people see benefit with eating yogurt, but usually the amount of colony-forming units in yogurt is much less than what you'll see in the actual supplements. Pick a product from a trusted manufacturer. This falls in, as an over-the-counter supplement, so it's not regulated by the government. So people can put, anything in those supplements, and probably getting these supplements from a reputable company is beneficial because they have a lot more to risk and a lot more to lose if their product is not safe and effective. Make sure that there's information on the label as far as the manufacturer, what's in the product, how to reach them if there's any problems, and recommended dosing. And then finally, they are quite costly. Like Cultrell, at least in the state of Ohio, for a package of 30, it costs anywhere between $20 to $25, and that's for, if you take one twice a day, that's for 15 days. So it can cost quite a bit of money to use these products. And just briefly to talk about some nutrition hot topics. We all know that nutrition impacts lung disease, and achieving and maintaining a recommended BMI is very important in terms of your overall lung health, although that's going to be a lot easier said than done. If you're consuming a high-calorie diet, taking enzymes, still struggling to gain weight, what are some other things that we're looking at in research and possible treatments to help improve nutritional status? That's the first couple of things I'm going to talk about. Growth hormone. This is a multi-centered trial that was published in 2011 in Pediatric Pulmonology. It was a multi-centered trial. And they did not use placebo in this trial because growth hormone is given by injection, and they did not want to inject placebo in children. These were all children under the age of 14. It was a very positive study. RH means recombinant human growth hormone. Significantly improved growth, weight, lean body mass, and lung function in terms of volume and flow in the patients that they studied. They also found no difference in the incidence of glucose intolerance, which is important because growth hormone can cause some insulin resistance, so they wanted to make sure it wasn't going to lead to diabetes in these patients. So that has some promise. One of the downsides to growth hormone is that it's quite costly. So it's being used in a lot of different areas right now, different disease states, and you can try to get that covered by your insurance. It is available clinically on the market, usually easier to get covered if you have a documented growth hormone deficiency. However, some people have used it, have shown that they've improved their weight and pulmonary function tests, and then fight with the insurance company to get it approved. But the cost can be anywhere from $10,000 to $30,000 a year, depending on the size of the child, so it's pretty expensive stuff. Insulin therapy, it's one of the recommendations to use insulin in patients who have CF-related diabetes. It improves not only body mass index, but it improves pulmonary outcomes. But we don't know what to do with people who are in this range for what we call impaired glucose tolerance. So that means when your blood sugar is anywhere between like 140 and 199 2 hours after glucola or after a meal. So it's not quite diabetes, but it's not normal either. And what does this mean for somebody? How is it impacting them clinically, and what can we do with them? So it's been a big area of research. There's been a lot of trials using long-acting insulin, such as Lantus, which acts for 24 hours, to see if it helps improve outcomes in people with CF. And there has been some promise in the studies. That first one mentioned there showed that it helped prevent the deterioration of lung function. The second study, which was published in 2011, didn't show any improvement in patients' BMI or pulmonary outcomes. However, they did show that it was well tolerated, well accepted. It's a very small, fine needle, so patients didn't mind taking it, and it also didn't lead to hypoglycemia, which is low blood sugar. So it seems to be pretty safe to use, and the authors concluded that maybe they need to use it in larger doses to see more of a clinical benefit to it. But it's something to consider if you're struggling with your BMI and you have a low BMI, or if you have impaired glucose tolerance. Vitamin K, one of the forgotten fat-soluble vitamins important in blood clot formation and bone health. It's difficult to measure. You can't directly measure a vitamin K level, unfortunately, so we usually check it indirectly through what we call prothrombin time, which is a clotting factor. However, when your clotting factor is off, that means your vitamin K deficiency is pretty severe, so it's a very late indicator of vitamin K deficiency. Vitamin K is often not found in over-the-counter supplements, so if you choose not to use one of the CF vitamin products, you're probably not getting additional source of vitamin K. And in the studies that we looked at, we're probably underdosing vitamin K, and just recently they increased those quantities of vitamin K in the CF products. So that last study there actually showed 50% of patients, when they used more sensitive measures of vitamin K status, had vitamin K deficiency. And they needed anywhere from 1 to 5 milligrams a day of vitamin K to bring those levels back up into the normal range. Kidney stone prevention, just want to talk quickly about this because I think it's often not talked about, but we know it's an increased incidence in people with CF. Stones are usually calcium oxalate, and we think that we see an increased incidence in people with CF because they have an absence of the intestinal bacteria, Oxalobacter formigenes. And again, when I was talking about the probiotics, there's this gut, the gut bacteria just isn't normal. Oxalobacter formigenes, is one of those healthy bacteria in terms of it helps to bind oxalate in the gut and degrade it. So if it's not present in that GI tract, you're not binding that oxalate. It gets absorbed into the body. It ends up in the urinary tract, and it can precipitate when mixed with calcium and form stones. People with CF also tend to have low citrate levels, which helps maintain the pH balance in the urine, and this can also increase your risk of stones precipitating in the urine. So what can you do to prevent or lower your risk of developing kidney stones? First of all, achieving adequate fluid intake to keep that urine dilute, making sure that you have adequate calcium, and that may seem counterintuitive because the stones are calcium oxalate. However, there's an inverse relationship between calcium intake and risk of kidney stones, and this is true outside of the CF population as well. So if your calcium intake is not adequate, your risk of kidney stones actually goes higher, and the reason for that is because calcium binds with oxalate in the GI tract, as well as that bacteria. So that's why it's associated with a lower risk of developing kidney stones. And also, you might want to consider citrate supplements. You can get citrate in the form of calcium citrate. So if you need to take calcium supplements anyway to meet your calcium needs, you might want to consider calcium citrate as a source. It's also available by prescription in potassium citrate supplementation. I have 2 minutes to talk about lots of slides. So, trying to think of what I want to go through here. Constipation and DOS, I wanted to talk about this because it's a common cause of abdominal pain and decreased intake. So those aren't always necessarily the result of inadequate enzymes. So there was a working group that just published in the Journal of Cystic Fibrosis the definitions of constipation and what we call DOS in people with CF. So that is available, but just some information there about constipation. And then DOS, this is a specific condition that we find in the CF population, and it's known as distal intestinal obstruction syndrome. You can get complete obstruction or incomplete obstruction. Complete obstruction is a medical emergency. Usually people are in so much pain they go to the emergency room. And what I'd like to say here is that it's really important that if you go to the emergency room with severe abdominal pain, make sure you contact your CF center because this is a CF-specific condition. Not a lot of people in emergency rooms have experience with treating this, and you may be improperly treated if your CF center is not contacted. I also want to put a shout out there for screening for colon cancer. We know that there's increased incidence of GI cancers in CF, particularly of the colon. And this, it's really mainly limited to case reports in the literature, but there's actually a case report of a 13-year-old and an 18-year-old developing colon cancer in CF. Transplantation probably further increases that risk because of immune compromise. So, I think that earlier screening is probably a good idea, than waiting till you're 50 to get colonoscopy. In Cleveland, we're starting with patients at age 35, and we've actually found quite a few patients who have polyps, precancerous polyps that were removed, hopefully preventing their development of colon cancer in the future. But certainly if you have any potential symptoms of colon cancer, definitely get screened. So my take-home advice, and I'm just going to let you read over those very briefly instead of going through them since I'm out of time. And just some, I don't know if this is going to be particularly helpful, but just from my aspect of working in the healthcare setting as well as being a CF parent, some things that I wanted to pass along. The first one is to seek help, and this is so much easier said than done. And I know this from a personal perspective as well as professional. I think any CF healthcare provider will tell you that the patients that struggle the most, and even our adult patients, are the ones that don't have a strong support system. And I think CF centers do a really good job of now of teaching our patients to become more independent in their care. However, we don't really teach that interdependence, that it's okay and encouraged to ask for help when needed. And I think it's particularly important to have an advocate within that healthcare setting when you're in the hospital, especially when you're really sick, to have somebody there advocating for you. And certainly being scared and depressed and anxious, those are forms of suffering not to be ignored. And it doesn't mean that it's a weakness to have these things and to seek help for them. And then, if somebody is one of your supporters and they're just not making you feel good with their support, that's not a true supporter. And then I just encourage everybody to get involved in healthcare quality improvement as much as you possibly can. And then take charge, know your test results. Don't assume that when you get your annual results that if you don't hear anything, no news is good news. Make sure your CF center got those results and everything's normal. Utilize the entire clinical care team. I've learned more from patients and families than I have from healthcare providers as far as practical tips for managing CF in the home environment. So please share those tips with your care providers, even if they're not explicitly asking you for them. I think adverse reactions to medications and treatments are way underreported, and we as healthcare consumers can play an important role to make sure that they do get reported. You can also self-report if your healthcare provider has not. And I also wanted to make people aware that at the North American CF Conference for the past few years, there's a family advisory board track on Saturday. So if you're interested in those types of conferences, medical science conferences, there is a Saturday track that's at a much lower cost than the full North American Conference. And that is available. You can ask your CF Center about that. And then published on the CF Foundation website are guidelines for a variety of different treatments in CF. So they have pulmonary guidelines, they have the vitamin D guidelines. Those are all available for you to review and help you become a more educated healthcare consumer. They also have published center outcomes. I can't emphasize enough the importance of telling your healthcare providers to wash their hands, and usually it's done very well in the CF clinic environment, but outside of that, it's not done very well. My daughter's unfortunately had a lot of trips to the bronchoscopy lab in the past year and a half, and it's so frustrating as a healthcare provider, not only as a parent, to have to constantly remind people to use hand hygiene, but I think the more we do it, the more they're going to get used to doing it, the less we have to ask. And then my final word of advice is to consider become registered as an organ donor.
Terri?
I welcome any feedback to you. My email address is there, so please email me with any advice.
Terri, please stay for a couple of questions. We have 5 to 7 minutes for those of you that have a question about nutrition.
I'm sorry for going through those slides so quickly.
No, you're fine.
So.
Well, I have 100, but I'm going to concentrate on 2. One of the